acute renal failure, acute kidney injury. So if anybody asks you during Viva, what is the definition of AKI? We have definition of AKI as per multiple criteria and definitions that are available. But if the examiner, listen to your examiner's questions very carefully, don't get deluded, don't get swayed away. If the question is define AKI in pregnancy, first thing, if you really want to impress your examiner, say that there is no consensus definition of AKI in pregnancy. It has been extrapolated from the already established definitions of AKI in non-pregnant patients. So we'll be discussing these criteria. One most popular, I think one you should definitely remember. The rest, if you remember and are able to speak out in your exam, it's like obviously a win-win situation. So first is by KDIGO 2012 criteria, which is a kidney disease organization which had given this wonderful definition. This is increase in serum creatinine of more than equal to 0.3 milligram per deciliter within 48 hours. So increase, suppose a patient had a baseline creat of 0.7. And it next after 48 hours, if you're repeating, it comes to 1. So don't say कि ma'am ये तो physiological range में है or it's just borderline. It is a sign of AKI if it is increased to 0.3. Even suppose this example I gave, one was just supranormal range. Suppose if the patient had a baseline of 0.2 and it comes to be 0.7 after 48 hours, there is rise of more than 0.3 in 48 hours. 0.7 being even in physiological range comes 0.3 to 0.7, more than 0.3 rise is considered as abnormal. You should label that patient as AKI. Or more than 50% within 7 days. So you have to keep on following AKI patient. Obviously, you will be following that patient for long and not discharge that patient immediately. If within 7 days there is more than 50% rise from baseline, it is also labeled as AKI. Or there is a decrease in urine output which is less than 0.5 ml per kg per hour for more than 6 hours. In a normal 50 kg patient, 15.5, this is 250 ml, less than 25 ml per hour in a 50 kg woman for more than 6 hours is labeled as AKI. So incidence of AKI in US is 0.4%. Sometimes it may be asked. However, they are more interested with the Indian figures. In India, the incidence of pregnancy in AKI is 3 to 5%, with this being the reference. So obviously, the next question that even if you quote any figure of incidence and prevalence, many a times the examiner has a tendency of asking kahan se pada, kidhar se aaya ye value. So for certain things you might as well remember ki kahan se aaya, certain references, not all. So 3 to 5% of total AKI is AKI in pregnancy. Mortality is nearly 5%. Coming to the causes of AKI, that is, they can be pre-renal, renal, and post-renal. So if this is your kidney, I know it looks bad, pre-renal, post, PRR and post. Pre-renal causes. We all know anything that causes decrease in salt to the kidney, which is happening in the systemic part of the body. Whatever is pre-renal is the systemic circulation. Anything that is affecting the renal perfusion causes pre-renal AKI. Any cause which is intrinsic to the kidney itself causes renal AKI, and any obstruction or any insult coming from post-renal systems causes post-renal AKI. Understanding each one of them one by one is pre-renal AKI. Something like abruptio placentae, hemorrhage, dehydration from hyperemesis gravidarum. OHS is not needed to be talked in pregnancy. Another is heart failure. So where we encounter these questions, these scenarios, I will take one case scenario of each so that you all remember. A woman with in first trimester comes with severe hyperemesis gravidarum. What is what definition of severe hyperemesis gravidarum? Can anybody unmute and just answer?